Good morning, it's Babak, Larian, doing a hyperparathyroidism Q&A session. So happy to be here. I've gotten so many wonderful messages from patients. You guys are, and people who have been encouraged by this, who've been able to take action, convince their physician that what they're feeling is real, it's not in their head, get to an answer, get to a solution. I couldn't be happier. In any case, I don't get on Facebook for any other reason except finding old friends perhaps, and then this has proven to be actually somewhat miraculous in that regards. In any case, let me start. We have a lot of questions. Let me start by answering some of those questions, okay? The first question I have is from Elizabeth Porzinski, I think. Excuse me if I've massacred your last name. Hello, Dr. Larian. Can you explain the correlation between active and inactive vitamin D, calcium, and PTH levels? Sure. Actually, let me spin you around. So, this is how the whole network works, right? It looks complicated. Let's start with calcium. So if your calcium levels are low, your parathyroid glands produce PTH. PTH goes to your bones and tells your bones release calcium. Right? PTH goes to your kidneys and tells your kidneys to absorb more calcium from the urine and give it back. In your kidneys, it activates 1-alpha hydroxylase, which also activates vitamin D3 to active vitamin D3. So 25 hydroxy vitamin D3 to 125 dihydroxy vitamin D3, right? Active vitamin D3 helps the kidney absorb more calcium, but also goes to the intestines and helps the intestines absorb more calcium from the food. So without active vitamin D, your absorption of calcium would be a fraction of what it would be with vitamin D being present, right? Vitamin D also goes to the bones and helps bones grow and get stronger, right? Vitamin D is made in the skin, then activated, goes through the first step of change before activation in the liver. The second stage is with PTH in the kidney activating it, right? Now, if you take vitamin D3 supplements, you bypass these steps, you come in here, and you have material for use, essentially, in terms of vitamin D. So the relationship between calcium, PTH, and vitamin D is that if your calcium is high, it negatively, if you can see, all the calciums all the sources of calcium that the parathyroid has access to, when the calcium comes up, it tells the parathyroid glands to have a negative effect, which means to shut down, right? And so calcium itself brings PTH down. PTH, and on the other hand, promotes increased calcium in the bloodstream. So the relationship between calcium and PTH is inverse. Calcium high, PTH low, calcium low, PTH high. Now vitamin D has an interesting relationship because vitamin D comes and decreases both PTH production and growth of parathyroid glands. So vitamin D, when activated, right, goes in here and shuts the parathyroid glands down, or slows them down, or decreases the activity of that, right? So that's the relationship. That's how those things relate to each other. So Elizabeth goes on to ask, I'm 9 months post-op with advanced pre-op osteoporosis, surgery done at NPC. My latest labs are calcium 9.5 in October, PTH of 19, calcium 9.8 in November, PTH of 22, vitamin D is 71, question mark if it's 125 dihydroxy. Probably not, because it would have to specifically ask for 125 to get it. Pre-op calcium was 10.8. I've been on 1,200 milligrams of calcium, 2,000 units of vitamin D3, and 500 to 600 milligrams of magnesium. My calcium fluctuates from 9 to 9.5 with higher PTH, PTH of 32, okay? And now it's 9.8. I'm still getting hypocalcemia symptoms when calcium supplements decrease, or bone pain in my hands, arms, and feet otherwise. Looking at the above data, can you please comment on the recovery process if I'm going in the right direction? My concern is calcium levels. Should calcium still be supplemented as being done? Is the supplement safe to continue? Can calcium overdose as taken? Very good questions, Elizabeth. I'm sure there's lots of other people who are on right now or will look at this who are wondering the same thing. So let me just elaborate. When you have hyperparathyroidism, although your calcium in your bloodstream is elevated, you actually are depleted of calcium in your body, because that elevation in calcium in your blood is not coming from you consuming too much calcium, eating too much calcium in your food, or having ice cream 7 times a day, or taking pills, or taking too much Tums and acids that are calcium in your stomach. It comes from your PTH going to your bones and grabbing the calcium out of your bones, right? So that elevation in calcium in your bloodstream comes from loss of calcium in your bones. 98% of the calcium in your body is stored in your bones. So when your bones start losing calcium, that calcium goes into the bloodstream, right? And then it gets excreted out in your kidney, right? Even though you have PTH that tries to absorb it back, oftentimes when you do a 24-hour urine calcium on patients who have hyperparathyroidism, you'll find that they are putting out a fair amount of calcium in their kidney, right? So the elevated calcium in the bloodstream, your kidney's job is partly to get rid of that excess. It does the best it can. It's not always very successful when it's fighting a parathyroid tumor or hyperparathyroidism, but it tries, right? In any case, so your elevation in calcium comes from loss of calcium in your bones. So overall, your total body calcium is actually lower. So once you do the surgery and you no longer have an elevated PTH to force the release of calcium from the bones start to grab calcium back and try to replenish themselves, appropriately so. They realize that the bones have gotten weaker. They do everything they can to strengthen the bones. And we know that to be true because a study in Columbia University that took 24 years to publish and review looked at patients who had surgery for hyperparathyroidism, and 100% of the patients who had surgery for hyperparathyroidism had improvement in their bone density, which 15 years after surgery was 10% stronger than before surgery. So this is even without taking medications or a concerted effort to increase the bone. This is just naturally that's what happens. So your bones are intelligent, supremely intelligent, and know to grab the calcium back and replenish themselves. So during the period after surgery, the bones are trying to regain their calcium loss, and your parathyroid glands are trying to figure out what they're doing, what their calcium is. They're trying to, they've been dormant for a while, so they're trying to start working and getting bigger. So during that time period, the struggle goes on between your bones and your blood, trying to maintain that calcium. So it is not a bad idea to have calcium-rich foods. Now, I personally prefer getting calcium, getting everything naturally through natural sources, meaning getting it through green leafy vegetables or dairy products. Less so dairy because of its issues, but more from green leafy vegetables, right? So if you feel like your diet is a lot of green leafy vegetables, you're having 2 meals a day with lots of green leafy vegetables, then you probably don't need calcium supplementation. If on the other hand, you're not, that's lacking for you, it's just not an option, you have intestinal issues, whatever else, or you cannot tolerate it, then you may want to take the supplements, okay? But you should get calcium during that. I would say during the first year and a half after parathyroid surgery, you should have a lot of calcium coming into your system, preferably from natural sources, right? Vitamin D also, get a lot of sun, get a lot of, if you don't have any skin issues or skin cancers or get sun, appropriate amount of sun for transformation. Eat foods that are high in vitamin D. And if you're not getting enough vitamin D, supplement it, because you're not going to absorb calcium well from food or anything if you don't have enough vitamin D. And vitamin K2 also helps with that process. So replenishing that. Magnesium also helps. So Elizabeth, you're doing all the right things, right? This up and down that you're going to see, the struggle between your numbers, is as a consequence of a real issue. And it's not an issue, it's a real mechanism, actually, I would say. Let me turn this around. So, under the normal circumstances, the relationship between calcium and PTH is this curve, calcium, PTH. And that relationship is this inverse curve, right? And that inflection point is your calcium set point. So if you had hyperparathyroidism and they removed one parathyroid gland that was abnormal, the adenoma, let's say, Elizabeth, the remaining 3 glands were dormant because your calcium level were much higher than the setting that they wanted, which is this number. So in the setting of hyperparathyroidism, this is what you get. You get a mutation in the calcium sensor in one cell in one parathyroid gland. That's what turns into a parathyroid. So this one gets a setting of 11, while the normal cells want a 9. So as the calcium goes up, the normal cells stop producing or produce very little PTH. And if you extend this curve, there's still minimal amounts of PTH being produced even at higher numbers by the normal parathyroid glands. So they're working, but just very minimally. And the tumor keeps getting bigger and bigger, and normal cells atrophy. So the normal cells that are not working will shrivel up and get smaller. It's just like muscles in our body. Our body works based on maximal efficiency. So parts that are working will get bigger, like muscles. You exercise the muscle in your left arm, you'll get big, huge biceps. And if you don't exercise the right arm at the same time, it's going to get smaller. That's because your body doesn't want to waste energy on that, you know? And so that's what happens with the parathyroid. Parathyroids that are not working too much will get smaller, so they don't consume energy unnecessarily, and the parathyroid that's working will get that, right? So when you look here, you have this tumor that's taken the whole system hostage. Your body wants to be here. The tumor is getting you to this point. Once you remove the tumor, right, and it's gone, the normal cells will try to get you to here, right? And so what that means is that you are now going to hover around this number. Sometimes you're going to be higher, sometimes you're going to be lower. But you're going to range from here to here. So if your number was 9.0, let's say, you would have ranged from 9.2 to 9.4. If your particular number is somewhere around 9.4, let's say, so if your curve is this, sorry, something like this. Work with me here. It's hard to draw upright. In any case, if this is your curve, you're going to have times where you're at 9.8, you're going to have times that you're at close to 9.0. And that's your range. That's normal, right? And so that could be just what you're doing, Elizabeth. You're just going through the recovery process. Your parathyroids are getting bigger and stronger and doing their job. They're fighting a bone that's trying to grab the calcium back, and you're doing everything you can to maintain, right? That could be the case, or it could be that one or all 3 of your remaining glands are abnormal. They were super suppressed because you had an adenoma that was much stronger, much bigger, and much more active, and now they're beginning to manifest. But when I look at your numbers, I don't get alarmed that way, right? When I look at your numbers, I see a parathyroid struggling to maintain, right? So I think you're good. So continue doing what you're doing, dear. Exercise, be active, take a lot of green leafy vegetables, and so on, and go from there. All right? Hopefully that helps, Elizabeth. Next question is from Deb Tal. Hi, Dr. Allen. It's Debbie Toluba. Hi, Debbie. You operated on me last month, and I'm so grateful to you for helping me when no one else would or could. Love you. Love you too, Deb. Just made my day. Thank you very much, Deb. Just a quick question. You removed 2 enlarged glands from me, and just was curious the difference between enlarged glands and hyperplasia. Thank you. God bless you, and thank you for taking normal calcium hyperparathyroid patients seriously. My pleasure. So let me explain again. Here we go. So under the microscope, when you look at a parathyroid gland, on average, a normal parathyroid gland is 50% these pink cells, right? And 50% these white areas which are fat, right? So under the microscope, that's what that looks like, right? Now again, emphasizing with this slide that when you have hyperparathyroidism, you don't have one big gland and 3 other perfectly normal sized parathyroids, you have 3 shrunken parathyroids, right? Even if you have 2 adenomas, the same thing. The other thing about hyperparathyroidism is that if you have hyperplasia, which means all cells in all 4 glands are abnormal, they're not always even. You can have asymmetric hyperplasia, so different sizes, okay? Now, moving on. When you have hyperparathyroidism, the number of parathyroid cells increase, the amount of fat decreases, right? So there is a gradation that goes from here to here, right? So it starts at 50-50, maybe 40-60 for some person, or 60-40 for another, but it starts at some point and starts going to 70-30, 80-20, 90-10, 95-5, so on and so forth, right? So if you look at this portion here, it looks like 98-99% is cells, right? So the cells look the same, you know, right? The cells look the same, right? It's just the proportion of fat. When you have an adenoma, you have a parathyroid tumor with a little edge of normal parathyroid, right? Because if you remember, parathyroid tumors develop, if you look at the parathyroid gland, one cell in there becomes abnormal, then it grows and grows and grows and grows and grows and grows, and the normal parathyroid atrophies and gets smaller and smaller until ultimately you have tumor with a ledge of normal, this ledge of normal here. So a parathyroid tumor with a little ledge of normal parathyroid. The only way you know for a fact that you have removed the parathyroid adenoma is if the pathologist cuts the parathyroid gland in this fashion that gets a little bit of an edge and that. But if the pathologist had cut in this orientation, this way, and missed that, all they would tell you is that you have hyperplastic parathyroid gland, right? Now, fortunately, most of the time they do multiple cuts, so ultimately they may, but if they don't, if they happen to do the cutting this way and get 100 cuts this way, they would miss that transition, right? So it just happens to be how the orientation is and how it's cut. So when you take out 2 parathyroid glands and the pathologist says, but we see hypercellular parathyroid glands, you don't know if you had hyperplasia you were dealing with or an adenoma, right? And that's a problem because you're left in a conundrum. So in your particular case, Deb, we took out 2 parathyroids that were larger during surgery. The pathology, I don't recall your pathology exactly, if they said they were adenomas or they were hyperplastic. Let's assume that they said hyperplastic. Because your PTH levels dropped during your surgery, then the other 2 glands were not hyperfunctioning, right? And so during surgery, because the half-life of PTH is 5 minutes, you had an appropriate drop in your PTH, right? Which told me that the remaining 2 glands were not active and hyperfunctioning at that point in time, right? And so it made me believe that more than likely you don't have 4-gland hyperplasia, but rather 2-gland adenoma, and you're going to be okay. In time, the remaining two glands will start working more and regain normal function. And so, parathyroid adenoma can be enlarged. A hyperplasia parathyroid gland can be enlarged as well, right? Both can be enlarged. Enlargement just tells you that the gland is abnormal. It doesn't necessarily tell you if it's an adenoma or hyperplastic, unfortunately. All right, moving on. It's really nice to hear from you, Deb, by the way. I appreciate your note. It just really made my day. Moving on to Deborah Violet. I saw a surgeon in Toronto last week. I had a failed surgery in 2017, but with another surgeon. Here's my note from the recent consult, dated November 7th. Dear Dr. Haroon, had a pleasure of seeing Deborah Violet at our clinic. She's a 51-year-old woman, underwent a 4-gland exploration in 2017. They had found the right upper, right lower, I'm going to write it down, right upper, right lower, and the left upper parathyroid gland, which was removed. So I'm assuming, Deborah, hopefully you're watching, that you're saying that the left superior gland was removed. Okay? They could not find the left lower. She did have preoperative MIVI scans before surgery, which showed activity on the left. However, what seemed to be a postoperative MIVI scan, which there were 2 of them, one showed no result, and the other possible right-sided uptake. And there's my thoughts on Cessna MIVI scans and their reliability. She underwent venous sampling here in Toronto General, which showed possible high levels of PTH just in the inferior aspect of the left neck. Venous sampling in the left neck. Okay. Should this be in the ectopic location? It is likely within the thymus itself. I performed a bedside ultrasound in the clinic today to visualize it in the lower neck just above the innominate artery, which is right here in the neck, artery that comes from your right side, goes to the left to go to your heart. Innominate is this portion of it as it's crossing over. There's a possible hypoechoic lesion within the thymus itself. This is difficult to know, or it could be in a lymph node, or, okay. The lesion is quite medial but looks towards the left side. Assessment and plan. Given a venous sampling, it would be reasonable to move forward the left-sided parathyroid exploration with a thymectomy. I did explain that I should move forward with surgery. The risks were discussed. Okay. All right. And okay. Violet says, and I will be booked in the next few months for surgery. All right, Violet. My thoughts on this. I think first, hopefully they only removed the left superior parathyroid and left the 2 right-sided ones in place. Hopefully your surgeon will have intraoperative PTH testing as well as intraoperative pathology testing, so that when they take out the thymus and cut the thymus, and usually the surgeon themselves cut the thymus to look and see if there's any area in there that looks suspicious like a parathyroid, so they can tell the pathologist to do that. Hopefully the surgeon will do everything that I'm mentioning to you, because then during the surgery they'll know if they'll be successful. I would also get a 4D parathyroid CT scan in addition, just in case you have an ectopic parathyroid that's not in the thymus, but rather somewhere else, not accessible to the ultrasound. And your Cessna MIVI scans, you can see one time they show one side, the other time they show another. Venous sampling is fraught with problems because, especially after surgery, because when you do surgery, blood vessels that form cross over. You know, when we're fetuses and we're being formed, our face is actually 2 separate components that comes together. So is our neck, comes together. So there is a separation in the middle, right? Well, that's 2 nostrils, 2 eyes, this philtrum in the middle of our lip and everything, right? So blood vessels on the right side, on one side of my face, the right side, don't cross over to go to the other side. They're here. But if I do surgery in the middle, when new blood vessels form to grow, they may cross over. So if this is happening in your thyroid, because you're doing surgery on both sides, and blood vessels form and go over, then when you do venous sampling, and you get activity in the left lower, you're not certain if that's exactly from the left lower or from a crossover blood vessel that has generated after surgery. So it's a little bit confusing, but I would say I would do a 4D CT scan. I would make sure that my doctor is going to do pathology during surgery and get PTH levels during surgery. So you go in with all the ammunition that you have and all the tools in your armamentarium for a repeat surgery, okay? That way you have the best chance of success. I wish you luck, my dear. Joe Carroll Hughes, Kiborovsky. Surgeon removed 2 right parathyroids in on October 14th, just recently. Prior septum UV scan showed possible adenoma, with pathology indicated no adenoma and no hyperplasia. Okay? Intraoperative PTH went up. The surgeon declared the operation a success, but more than 1 month post-op suggests otherwise. I would say so. Calcium is 10.6, PTH of 70, vitamin D is normal at 39. I've been dealing with numerous non-specific symptoms. For over a decade, I have sucked the quality of my life. Suggestions for my next step. Well, at a PTH of 70, let me show you this. At a PTH of 70, let me show you this study. So this is a combined data from both Johns Hopkins and Geisinger Health System in Pennsylvania. They looked at their data about PTH levels and the accuracy of the septum UV scan. When their PTH was over 150, the septum UV scan was 83.7% accurate. PTH less than 150, 70% accurate or 69% accurate. PTH less than 100, 54% accurate. So your PTH level being 70 means that the septum UV scan is only going to be 50% accurate. You can't depend on it. It didn't serve you well on your first surgery. It's not going to serve you well in your second surgery. So that is a modality I would suggest you not use to try to figure this out. I'm not opposed to using it. I'm saying don't depend on it 100%. Let's say if you had come to me, what I would do is I would look at your pathology report and labs prior to surgery and after. Your surgery report to see if your surgeon went on both sides or just limited the surgery on the right side. Then I would do a 4D parathyroid CT scan to try to locate it. If on ultrasound I don't clearly see the abnormal parathyroid, right? So the possibilities for you are that you have a parathyroid that's abnormal, most likely on the right side, an adenoma, right? Or you may have hyperplasia, that all 4 glands are abnormal. And the degree of cellularity, again, if you go back to this, the degree of cellularity here is that if you have asymmetric hyperplasia and the degree of cellularity is going from the 50-50 cells to fat to, I'd say 90-10, right? 90% cells and 10% fat here. There is the staging from this to that, right? And if you originally were starting at 50-50 and now you're at 70-30, a pathologist will have a hard time saying you're hypercellular because the difference under the microscope is not a lot. And I'm saying this, if you were to look at this side of this slide and just not that side, right? This looks like, this looks like 75-25, maybe even 70-30, right? And this is 50-50. A pathologist will have a hard time saying that this is abnormal and this is normal because the difference is not dramatic, right? Now, if you were to look at just that section on here, they actually look fairly similar, right? So there's a degree of error. There's a degree of problems that you have from a pathology report, right? So just because the pathologist said they don't see hyperplasia or adenoma on your pathology report doesn't mean you don't have hyperplasia, right? So you need to have a surgeon that's very experienced, do your repeat surgery, to keep all this information in mind, to do a surgery that's going to take as long as it needs to take, to be patient, to take the specimen, look at it under the microscope, have the old specimens potentially available to compare, all sorts of information to help you along the path. But an ultrasound, an experienced surgeon, potentially a 4D parathyroid CT scan before moving on. But unfortunately, certainly you still have hyperparathyroidism. Best of luck, Joe Carroll. Trifina Eden. Hello. Where would I find the lost amount of information about the effects to the brain with those illness? Thank you for your time. I will probably miss your live as I'm in Australia. Well, I mean, there is an abundant number of articles out there. I would try with PubMed. PubMed as a good source of finding journal articles, which will show you what articles are out there. But I mean, that's really the resource to look at. PubMed online. And once you get on PubMed and you see the articles, then you can go to the site of the journal and purchase the article. So if you want to read the whole thing, more than just the abstract. Okay, Trifina? Kelly Flanagan. Hi, Kelly. Is there anything that you'd prescribe to calm down nausea? It seems I can't eat much without feeling really sick afterwards. A hard question to answer, because post-surgical, we can give short-term nausea medications. Zofran under the tongue can help. We give that to cancer patients. Potentially that may be something that you can have. I know ginger really helps with nausea, so having ginger ale and ginger can potentially be something that can help in your situation. I know a lot of cancer patients that I've had have used cannabis products to control the nausea. That seems to be fairly effective as well. And nausea medicines are, again, good and bad, because if you have it with every meal, then you need something with more regularity. And so I would try to stick with more natural things. But you need to see a gastroenterologist to help guide you as well. Okay, my dear, I'm so sorry, Kelly. I know you, and I obviously know you well, and I'm so sorry you were going through so much. In any case, best of luck, my dear. Joanne Gary Zurek. Hi, Dr. Larian. How are you? I'm well. I slept well last night. The kids didn't wake me up so much. They had mercy on me. I had 3.5 glands removed April 2019. 2 adenomas plus hyperplasia. Okay. They left a small piece in my neck to work. Will I remain hypocalcemic after surgery if I have been hypo for the past 6 months? If you have been hypocalcemic, well, it's hard to answer. But let me read the rest and I'll explain. And does your PTH usually drop continuously while you're hypocalcemic? My numbers look like this. Post-surgery calcium was 7.6, calcium now is 8.2, okay? Take 2,800 milligrams of calcium per day. D3 was 34, now 42, so that's good. I also take 1,500 units of vitamin D post-surgery. PTH level was 10, went to P40. That's normal. That's great. Stayed that level till the last month. Now PTH dropped to 28, but 28 is normal. Again, remember, you're going to have that range of calcium, right? So your last remaining parathyroid gland is going to have that curve that it follows. So calciums go up and down, and PTH going up and down, and that range is appropriate. My mag level was 1.6, I stayed that level. My phosphorus was 6.7 post-surgery. On calcitriol, now phosphorus is 4.7, which is great. 24-hour urine calcium is 52. Okay, a little bit on the lower side, but that's okay. It's not bad. As well, trying to take hydrochlorothiazide, felt terrible on it. I'm not sure why you would take hydrochlorothiazide. Hydrochlorothiazide is a calcium sparing, so they think your calciums are too low for you and trying to, okay. Let's move on. Only 2 doses had to stop, just started calcitriol, okay, but my symptoms are increasingly bad: spasm, numbness, facial burning, nerve pain, loss of concentration, bone pain, etc. I also take multivitamin B12. I'm a weight loss surgery patient as well, so malabsorption syndrome, kidney function is normal. What are your thoughts? Thank you so much for all you do. Okay, so let me spin you around. I think something very important that needs to be considered for you and a lot of patients is this. Sorry. Going back. Let's see. Going back here. Okay. PTH goes and activates your vitamin D from 25 hydroxyvitamin D, which is when people say we've done your vitamin D test and this is your result, they're usually talking about this because this is the more stable form of vitamin D, so that's what it goes in your bloodstream, and then it gets activated and immediately used in the kidney by this enzyme in the kidney that activates the vitamin D to the active form, the 125 dihydroxyvitamin D. This is the one that does all the work. This does no work. This one is the one that does all the work, right? So when this one is present, it'll go to your intestines and help you absorb. So if you have malabsorption issues, you may not be absorbing as much vitamin D as needed. But fortunately, you take a lot, and your vitamin Ds have been in a good range. I would say that you should check your PTH level. Do a test where you're checking your calcium, your PTH, your albumin, your ionized calcium, your 25 hydroxyvitamin D, and 125 dihydroxyvitamin D to see where you stand with that. Because if your 125 is low, that's where calcitriol would help. And if by taking calcitriol you find that your symptoms are significantly better, then you know that your bariatric surgery, your gastric bypass, is part of the issue, right? And it's not allowing you to absorb adequately, which could be, if you had chronic vitamin D deficiency, cause you to have secondary hyperparathyroidism and hyperplasia and so on and so forth. Okay, but it looks like, based on your PTH number, that the remaining parathyroid is functioning appropriately. Now, the other thing that I would say about your calcium levels is that I think you really need to study this for yourself, is that in the patients who are, let me bring this up, in the patients that are normal calcemic, the issue that we have is, let's see, that's not it. The issue that we have is that if you start with the calciums being set for normally 9.5, and then you go up 1 degree to 10.5, that's an equal amount of disease and impact on your body than if your calcium wanted to be 8.5 and it's gone to 9.5, right? So if your calcium wants to be 8.5, right, you're going to range from 8.1 to 8.7 most of the time, right? And when you're doing your blood test, if your doctor checks your blood test and sees that some of the times you're here, they may say you're hypocalcemic, but it may not be hypocalcemia for you, right? And so that's an important bit of information, right? And so I think it's better to treat more your symptoms rather than your calcium numbers. Unless you can go look at your labs from 20 years ago, 25 years ago, and find calcium levels. And if you find that consistently your calcium levels 20 years ago was 8.1, 8.2, then you know that you don't need to go to a higher number. That was your setting, and it always will be your setting. If, on the other hand, you find that your calciums were 20 years ago, your calciums were 9.5, right? And now you're hovering in the 8.2s, and before having surgery, your calcium was 11, right? Then your calcium is too low, right? And you need to hover around the 90s, right? And then you can increase it. So that's a helpful way. If that's not working, if you don't have access to that information, then you have to, now that you're taking calcitriol, first see if that does the job. If calcitriol does the job, then you're good, you're absorbing better. If it doesn't, you may actually have to increase your calcium intake. And I would say, try many different ways, try many different sources of calcium to see which one works best with your malabsorption issues, okay? They're a tough situation. I find the gastric bypass patients to be in kind of a tough spot in trying to maintain, all right? Best of luck here. Sally JP, hello Dr. Dali. Would you please be able to give us examples of expected drop in PTH for people with normohormonal hyperparathyroidism? Yes, I can actually show you a slide. Here we go. So the folks at Cleveland Clinic did a nice study where they looked at their calciums and their hyperparathyroid. They found that the very high PTH patients showed a drop in PTH that brought them into the normal range, but upper normal range. The mid-range people, 80s, came to the mid-range of normal. The normal hormonals started around 40s. Once they were done with surgery, averaged around 20. So more than a 50% drop. In each case, you can see more than a 50% drop. So more than a 50%. So it doesn't matter what number you start at. So your intraoperative PTH should drop more than that. And once the surgery is done and you're following the patient, in the long term, they should be lower. That thought with normal hormonal patients is that their range of normal is not 15 to 65. Potentially this person's range of normal here, and let's do this in green there. This person, the normal hormonal range of normal, may be 10 to 30, right? And a number of 47 is significantly higher than the upper side of normal for that individual. That's the idea behind it, okay? Hopefully that's clear enough, Sally. Joan Nino, thank you very much for the Q&A. My pleasure, Joan. It's so kind of you. It's my pleasure again. You give hope to patients around the world. I'm so happy. You and the Facebook group I'm in have been vital in helping me cope with this disease. That's wonderful to hear. Thank you. Thank you. Yes, of course. I have primary Sorry, I'm trying to get to this so that I can answer everyone's questions. I have primary hyperparathyroidism. One gland has shown up on a sesame scan, but concerned that the scan wasn't done properly and therefore the results may not be accurate. I only had one scan after the injection. I had been told there would be 2 scans within a few hours in between. Could one scan without the second scan give a false positive? Yes, yes it can. Because you could have a thyroid nodule or an ectopic thymus or all sorts of things that could show activity. But if the second scan shows dissipation of that activity in a parathyroid, but a thyroid nodule may be less likely to show that going away, but it still could. Would a second scan give me more information? Yes, it would. The surgeon said that the scan showed the gland is a top gland that has dropped down to the position where the bottom gland should be. Have you seen this before? Yes, a lot. Actually, the most common ectopic position for the top glands is to come lower in the neck and be just deep. So the bottom gland usually are superficial, the top glands are usually deeper. So these, when they drop, they end up being deeper than the superficial. So you can have actually 2 of them next to each other. One superficial, the nerve goes in between them, and one deeper. Okay? So surgeon seems like they know what they're talking about, fortunately for you. Okay. I'm due to get surgery. The surgeon said she won't use intraoperative testing as she doesn't need it to recognize the parathyroid gland. Ooh, okay. Do you think that the surgeon will 100% be able to identify a parathyroid gland and also identify the bad parathyroid glands without intraoperative testing? I'll tell you an interesting story. I went to visit a really famous surgeon once, and does multiple parathyroid surgeries a week. And I just, I try to do this. I try to go see other surgeons and see what they're doing. Always learn something, right? And I went in there. This person was actually really a smart, brilliant guy. I respected him a lot. I looked at his stuff, and I went to see him just to learn, get some pointers, right? This was maybe 2 years ago, a year ago. In any case, during the surgery, this was a repeat surgery. He had prior to surgery, he had done an ultrasound, had done a needle biopsy, right? And in the needle, he had seen parathyroid hormone. So he was convinced that what he had seen on the ultrasound was exactly the parathyroid. During surgery, brought the patient in the room, went to what he saw in that area, and removed that. Didn't send it to the pathologist, right? And said, okay, we're done. Surgery over, patient is cured. And interestingly enough, did do PTH levels, and the PTH didn't come down, and said, this is a revision surgery. I'm not going to go to other parts because I don't know where I'm going. Closed up the patient. Was convinced the patient was going to be fine, even though the PTH didn't drop, and the final pathology showed that he had removed a portion of the thyroid and some scar tissue, which I'm not blaming him actually. I would, it's, when you do repeat surgery, it's harder to find things, right? And so, although I would say, in my hands, I'd say 90% of times, not maybe 95% of the time, I know that I'm taking out a parathyroid, and I found that the pathologist really just confirms what I know and doesn't really help. It's those 5% that make a difference. And I'm not sending specimens to the pathologist, and I'm not doing PTH tests for the 95% in my practice. I'm doing it for the 5%, right? And the surgery does take longer, but I get information that helps, and so I would say that probably 95% of the time your surgeon doesn't need it, but you got to do something. If you're not going to do pathology to confirm that you have parathyroid, you should be doing PTH testing. I do both because I really want to have confirmation. Maybe it's overkill, but I want to have confirmation that I'm doing the right thing and the patient is not. And I also do that because the great majority of my patients are from out of town. So I don't want them to leave and have to come back. I want confirmation during the surgery that I've done what's best for them, And so I would do things differently. I would do the intraoperative. Now, if they're doing PTH testing, then looking under the microscope is not quite as important, right? But that's what I would say. Now, there's studies that show that if you do 2 scans that show the same area, so if you do an ultrasound and a sestamium, both show the right lower one being the abnormal one, you have a 93% chance that just removing that is going to be curative. So there are statistics following that, but I still would do more. Okay. Do I think the surgeon will be 100% able to do? There is no surgeon that does anything 100%, unfortunately. There's no doctor that does anything 100% of the time. So I would say as 100% accuracy is godlike and not surgeon-like. And so, no. The surgeon said she'll remove parts of my thyroid if she can't find the parathyroid gland. Does that sound like a good surgical plan? If your surgeon has done an ultrasound and sees your parathyroid, and inside or sees something suspicious inside the thyroid gland, then removing a portion of the thyroid is reasonable. But if you do an ultrasound and you see a perfectly normal thyroid gland, and you don't see any areas that are suspicious for a parathyroid, removing a thyroid is not meaningful. Okay, so that's what I would say. So you have to have a concise plan. I don't want my thyroid removed as I don't want to get thyroid problems, but it seems like I won't have a choice if she can't find the gland. Again, the surgeon is relying entirely on the system EV, which I'm not sure has been accurately done. Joan, do an ultrasound. Start with an ultrasound, okay? That's an easy enough thing to do. Your primary doctor can order it. And have them look at, most likely you're going to have a successful surgery, first and foremost. But again, all the extra precautions you take is for that certain percentage of patients that have ectopic parathyroidism, unusual location, more than 4 parathyroids or less than 4 parathyroids to begin with, and then can get into problems, or have more than 1 gland abnormal, or all 4 glands abnormal, or 5, 6, 7, 8 glands, whatever number, getting more information before you get into the operating room, not depending on a surgeon's visuals to be 100% answer to this problem is the wisest thing to do, is what I would say, okay? So best of luck with that, Joan. Lala Woods, hello Lala. Thank you for all you do, my pleasure. My numbers have been, okay, it's been nearly 2 years since my first high calcium test. My numbers have been as follows: 10.9, 10.7, 10.5, 10, mid to high 10s. The latest is 10.3. PTH has never been about or above 79. Okay. Vitamin D has been 35, 29, 19, 22, 26 is the latest. I've been taking 1,000 units of vitamin D. My latest numbers are fairly normal. So by that you mean calcium of 10.3, PTH of 26. I'm not sure vitamin D of 26. I'm not sure what your PTH is. I have no kidney stones, I guess, or osteoporosis issues. I have pain, anxiety, insomnia, and fatigue. My ultrasound sensitivities were negative. 4D scans showed that the endocrinologist says is likely small adenoma. Endocrine surgeon says could be anything. I'm not a surgery candidate. She says the risks outweigh the benefits. I'm 57, 65 pounds overweight. I do agree with that my numbers improved with vitamin D. Just curious. Okay. Lana, you either have hyperparathyroidism or you don't. Okay? First and foremost, if you have hyperparathyroidism, it can have an impact on your body. And that's it. Fortunately, you don't have kidney stones or osteoporosis. That's good. So those are not the impacts. But you have to look at your numbers in general and see if the behavior is the curve, right? So if your parathyroid gland is doing this, right? We're functioning normally, and let's say your body likes a calcium of, your set point is 10.0, right? And if your curve is something like this, you get, and your calcium is, let's even change it. Let's say your set point is 10.2, the upper limit of what we call normal, right? Which means that your curve is gonna look something like this, which means that you would get some high 9s, right? And you get some high 10s, right? But most of the time, you would range, let's recreate the gray box for you, you would range somewhere like this, right? So you would be ranging 10 to 10.6, let's say, which sounds like your numbers mostly. But if your calcium is 10, right, your PTH would go up to 79. And if your calcium is 10.8, your PTH should be 20, right? So if you're getting that, if you're getting this inverse relationship, Lala, right? Where when your calcium is 10.8, your PTH is 20. When your calcium is 10.0, is your PTH is 79. Then your body just likes 10 as a number. And the symptoms that you have of insomnia, fatigue, pain, and anxiety is not from your parathyroids. And if you have access to your old labs, and 20 years ago your calcium was also 10.2, 10.1, 10.3, then that's just how you exist. If on the other hand, your calciums are always these 10 numbers that you're mentioning, and your PTH is never 20, 15, it's always 50 and above, then you have hyperparathyroidism. Now you can characterize it and box it into anything you want. You have hyperparathyroidism, and you're going to have progression of symptoms as they go on. And if you have a target on the 4D CT scan, it may be a good idea to proceed and manage this disease because you're having symptoms and it is affecting your quality of your life. I think that's the best way I can package it so you can try to balance it for yourself to make sense if the risks and benefits make sense for you. It's not necessary for them to make sense to your doctors. It has to make sense for you so that you can tell your doctors, I'm willing to take the risks of this surgery and to do it or not. Okay? Clearly you're intelligent and you can make these decisions for yourself. Alright? So that's where I would go. Alright, moving on. Best of luck, Lala. I know you're having problems trying to make this decision, and that's why you've been on Facebook with us for such a long time, and I don't fault you, not at all. I don't fault any of you who are on this side because you all have a disease that's not easy to understand by you, and you probably understand it better now than most of the doctors you've dealt with. Okay, moving on to Judith Schechter. Hello, Dr. Larian. I had 3.5 glands removed 6 months ago due to hyperplasia. Blood work recently over the past few months showed blood calcium 8.8. corrected to 8.3, PTH of 17. I'm no longer having symptoms of hypocalcemia. Over these months, I've been on 1,000 to 1,500 milligram supplements of calcium and 0.5 microgram of calcitriol daily. I have 3 questions related to my situation. I like where you're going, Judith. Are there ill effects of long-term use of calcitriol at a dose of? They are not. No, not that I'm aware of. But what I would say is that when you do blood tests, check your calcium, your PTH, albumin like you are doing, right? As well as 25-hydroxy and 1,25-dihydroxy. Because just looking at 25-hydroxy is not going to tell you what calcitriol is doing because calcitriol is 1,25-dihydroxy. So if you check your labs and your 25-hydroxy is low, but 125 is high above the normal range, then you can get toxic with it. But if you're with the dose of calcitriol that you're taking, your 125-dihydroxy is, let's say 50 or 60 within normal range and not close to toxic, then you're good to go, right? So one very good question. 2, might my low PTH levels be due at least in part to direct effects of calcitriol? Yes, it can be. Calcitriol suppresses, remember, the parathyroid growth, parathyroid function. Do you have any suggestions about moving forward towards normalizing my blood calcium? Yes. Exercise. Get calcium from natural sources. Check your 125-dihydroxy as well as 25-hydroxy. Get those levels in place. Because if you're producing PTH adequately for yourself, right? Especially if your PTH levels before you had surgery were not 300, if your PTH levels were 70, just like I showed you for the normal hormonal patients, maybe PTHs around 20 and 30 are normals for you, and you're being suppressed by calcitriol, so you're down in 17 range, maybe you're totally fine. All you have to do is actually stop taking extra stuff, have calcium supplements, or have calcium from normal dietary sources. If your calcium at 8.3 was abnormal for you, you would have symptoms. And if you're not having symptoms, then maybe your body wants a calcium of 8.3, and that's where it needs to be, and you don't need to overthink it, right? And your doctors don't need to overthink it. So I think you just need more information. But you're clearly very bright. You have asked 3 brilliant questions. You're going to figure this out. You just need more information, all right? Thank you for sharing with that. These are good questions. Susan Mary Davis. I had surgery 6 years ago. PTH was 278, calcium 10.9. Then a medical student would be able to diagnose this one, right? This is textbook. Vitamin D at 9, so not so textbook. 24-hour urine calcium 511. All right, all the symptoms of hyperparathyroidism. Today my PTH is 100. Vitamin D is 21, now 40. After 3 months of vitamin D, no change in symptoms, and calcium is 9. Doc says he does not know what's wrong with me, but he's treating me for secondary hyperparathyroidism by prescribing vitamin D and recheck in 3 months. I have the same symptoms: painful hips, legs, muscles, weak, peeing a lot, eye issues, insomnia again, but more gut issues such as bloating, upset stomach, etc. I have assumed over the years that my symptoms prior to surgery were because of high calcium. Can elevated PTH alone cause my symptoms? Yes, yes it could. And you don't know if calcium of 9 is your normal calcium. That could be high for you as well. You need more information. Could living so long prior to my surgery 6 years ago with high calcium affect my stomach gut in the long term? It would, but it wouldn't cause you further issues down the line. The issues in the gut would be persistent from that time and continue and not necessarily improve, but I don't think you would be normal with your gut and 6 years later start having intestinal issues. I'm having a 24-hour urine test on Monday after requesting it from my doc. Thank you for answering. So I would get a prescription from your doc for calcium, ionized calcium or albumin, PTH, 25 hydroxyvitamin D, 125 dihydroxy. I would check your magnesium and phosphorus as well. I would check your creatinine level at the same time. You want to look at all these numbers and see how everything is functioning and how you're doing, because you may need to supplement differently based on these numbers. You may need to take more magnesium as well to help stabilize it. You may have low 125 dihydroxyvitamin D, which would mean that you need that supplement rather than just plain vitamin D. So you need a little bit more information to decide how to do it. But at a vitamin D of 21, hopefully you have secondary hyperparathyroidism and you can correct it by taking supplementation in the form of vitamin D and vitamin K2, okay? Hopefully that'll do the job for you, so you won't need to look at a surgeon ever again. All right, my dear, best of luck. The last question here is from Kareem Kabuk. My calcium is 11, PTH is 116. My adenoma is near the carotid artery, I'm afraid. Oh. Kareem, let me put your fears to rest, my friend. Let me show you. I'm going to go through a sequence I drew for surgery for patients to understand. So this is a sequence for parathyroid adenoma removal. This will apply to you, right? So this is the anatomy. Neck, lower neck where I make the incision. This is the cross section of the neck. Looks like that. Incision here. Fat under the skin. These are, let me do it in blue, muscles over the thyroid gland. This is the thyroid gland, right? This is your breathing tube. This is your swallowing tube. Takes the food to your stomach. Number 11 here is the carotid artery, right? Number 4 here is the vocal cord nerve, and number 6 is our parathyroid adenoma in this picture. But let me show you the distance from this adenoma to that carotid artery is not much. So when we do the surgery, we make the incision, separate the skin, and immediately as you're looking down here, this view here is as if your eye was looking downwards, right? So you see the skin being pulled apart. You see the two edges of the muscles here and here. All right. Then a retractor pulls the muscles aside, so you see the breathing tube and a portion of the thyroid there. A second retractor will push the thyroid away, and once you do that, you can see the nerve, the parathyroid gland, and the carotid artery. Nerve, parathyroid gland, and this is, my friend, the carotid artery. I'd say 99% of the time when I find a parathyroid tumor, it's either sitting right next to the carotid artery or within a few millimeters of the carotid artery. There's not a lot of space. So, Kareem, the fact that your parathyroid is next to your carotid artery is absolutely not a problem at all. Not a problem at all, okay? Take care of your gland. I take parathyroids around the carotid all the time. I'm seeing the carotid practically every parathyroid surgery I do, okay? Practically, not 100%, but practically, okay? And it's not a problem. The carotid artery is a very strong blood vessel. It is very thick, so injuring the carotid artery is hard to do, fortunately. All right, let me check in and see if there's any more questions that have come up since we've started. Bear with me. All right, let's see. Yeah, a few have come in. A lot have come in. All right, let me go through them. Joyce Morris had surgery on October 1st, 2019. Post-op PTH was tonified. Had 2 hyperplasia glands removed, leaving me with only 1 healthy gland. Had 2 hyperplasia glands removed. Okay, so I'm assuming that your surgeon. Joyce, that your surgeon is certain that you have only 3 glands, right? So you have 2 glands were removed, 1 was left behind. Okay, all right. Felt pretty good after surgery. 4-week PTH was 55, vitamin D 40, calcium 9.2. Had more blood work yesterday. Now PTH is 65, calcium is 10.1. Vitamin D not in yet. Try not to panic. Don't panic. You don't need to panic. But I don't like upward trend, feeling okay, but not as good as right after surgery. Okay. Joyce, there's actually articles out there on patients who have elevations in their PTH after surgery, and the thought is that it's a version of the hungry bone syndrome, where the bones are grabbing the calcium back, and your parathyroid that now is more active since it's recovered from your surgery is working harder to counterbalance that. And by producing more PTH to fight that, your calcium comes up along with it, and so on. So what I would say is, make sure you're getting a lot of calcium through your food, or take supplements. Make sure you're getting a lot of sun and vitamin D sources, okay? Make sure you do all these things so you can continue to boot your system and supply enough for the parathyroid glands to be doing fine. And then this may continue for 6 months until things balance out, okay? And don't be alarmed. I have lots of patients who go through this period, and then the calcium and PTH just come down and normalize and stay down. So don't panic. That does happen, unfortunately. Best of luck to you. Tammy Morella Hartenbauer. For people coming from out of town for surgery, could you explain the process from the initial phone consult to the surgery itself? when it's safe to call. What is your average surgery time, average time of discharge of the patient? Hey, thank you. First and foremost, you're never discharged as my patient. You stay my patient forever. You get my cell phone, you stay in touch with me so that when you go home, we can communicate so that I know what's happening with you, and you have less anxiety with your recovery because you have access to me. Because when I find my patients are less anxious, they heal better. And so I have patients that are sending me labs 5 years after surgery, 10 years after surgery, and I'm looking at them and making sure they stay okay. So that's all okay. In terms of the process, I don't want to bore everybody else, but just to get a general idea, patients, usually I order a blood test. I get the diagnosis of hyperparathyroidism before you come into town. I confirm it with your blood test. 99% of the time that's doable. I'd say 1% of the time we need to do more than blood and urine tests to figure you out. I order scans in advance, and if you're in a place that can do the scans locally, then the scans are done so I can find the parathyroid and get adequate information for surgery. If you're in a place where we can do appropriate scans, then I'll arrange when you come in on the day before your surgery. So you come the day before your surgery, I see you, I do an ultrasound. If the ultrasound that I do shows the abnormal parathyroid, great. If it doesn't, I arrange for you to have either a 4D parathyroid CT scan or a SESTA-MEB scan based on what your numbers show me, and I think which one of those is appropriate, okay? And then the next day is the surgery. Obviously that day we go through the risks, the benefits, all the issues going along with it. I give you calcium and magnesium and vitamin D supplementation to take starting immediately the night of surgery. So the next day the surgery is done. Surgery almost always is outpatient. You come and get the surgery, you go home, unless you have heart disease or lung disease or something more complicated, or kidney failure, where I need to keep you at the hospital. I usually do these surgeries on an outpatient basis at an outpatient surgery facility, because they usually don't have the infections that the hospitals carry because they have sicker patients, right? So that the surgery is done. The surgery can vary the amount of time of the surgery. It can be as short as 15 minutes if you have a parathyroid adenoma that's superficial under the surface, that I don't have to go find the nerve and go underneath the nerve and move the nerve around to get it out. The surgery can be 15 minutes. If it's underneath the nerve and I have to protect the nerve and get the nerve, it can take 30 minutes, 35, and whatever amount of time it takes for me to protect your nerve to get it out. If you have more than one gland that's abnormal, that can take longer, but the surgery itself can usually averages 15 to 30 minutes, right? Unless you have multiple glands that are abnormal, they're in unusual locations, they're inside your thyroid gland, they're down in the thymus, or all 4 of your glands are abnormal and hyperplasia, which can take longer. It takes as long as it needs to take for the surgery to be done appropriately for you, right? And that's what I say. I know there's a lot of emphasis in doing a surgery that's 15 minutes, and that emphasis would be perfectly awesome 30 years ago, where anesthesia was more harmful than the surgery itself, but now we have anesthesia that's more controlled, less toxin, and more of a sleeping medication, right? So they create a sleeping state as opposed to a coma state, you know? In any case, so the surgery is safe and sound, and it takes the amount of time, but majority of patients fit into the 50 to 30 minute category. It does take another 30 minutes to get PTH results and the pathologist to look at the parathyroid under the microscope. Once that information comes in and it confirms that the PTH levels came down appropriately, the surgery is done. You go to the recovery room. Majority of patients I do surgery under block without a breathing tube, without what's called an LMA or a laryngeal mask anesthesia. You breathe on your own. You may have a mask on your face and nose or your nasal cannula, and I give you blocks in your neck to do the surgery. So it's really truly under local anesthesia. And once you get up, you're in the recovery room for about an hour, and then you go home. You take calcium and vitamin D that night, and calcium, vitamin D, and magnesium as of the next day. You can fly home if you don't have complicated medical history the next day. So usually the patients come, let's say, on a Wednesday. I see them. They go to surgery on Thursday. They fly home on Friday. Something to that effect. Okay, and they have my number, so we do things. For patients who have 1 or 2 gland disease, I check calcium and PTH and vitamin D at 1 month and 6 months. The ones who have 4 gland disease, I check it at 1 week, 1 month and 6 months, or more frequently if they have more calcium needs, but they have access to me, and we're communicating on the phone all the time, texting, emailing, whatever. All right, hopefully that helps. Cara Evans Rose, 2 adenomas plus hyperplasia removed in April. PTH is currently 129, calcium 9.5. Surgeons saw the other 2 parathyroids and they looked fine. Surgeon says wait, but I have osteoporosis already at 48. In April, it's been 6 months. If your calcium, if your PTH is not down, and if your vitamin D is normal, so if you've been able to normalize your vitamin D, the calcium of 9.5 and a PTH of 129, then you have hyperparathyroidism. You need to have it treated, right? The unfortunate thing is that your surgeon did look at the parathyroids on the other side, which means you'll have more scarring, so you should do the surgery either with this particular surgeon or someone who's experienced, and use a breathing tube that has the nerve monitors on it for repeat surgery. Vicky Shire Milford, good morning. If calcium run high 9s and one-time pain, is that an issue? No? Have had both high PTH and low. Vicky, I need more of a picture to be able to tell you. But if your calciums are high 9s and low and one time in the low 10s, and your PTHs are always hovering high, but you say high, I got to see your numbers there. I got to see how these numbers are working, and as well as your vitamin D and all the other sets and your 24-hour urine calcium. This is too brief of a summary for me to be able to give you an adequate answer. Can the procedure at NPC help determine which parathyroid is, or you're going to have to ask Dr. Norman and his team about what they think. I can't comment on how they do their procedures. They'll be the experts at that. But hopefully, Charles Hickman, can primary hyperparathyroidism affect your eyesight? I've found since I've gotten ill, my eyesight to be really blurry. I actually find that to be not an uncommon complaint, Charles. Patients say that when my hyperparathyroidism is active, I have to use my glasses, and when I get treatment, I stop using my glasses. I have a feeling that because it can cause muscle weakness, your lens adjustment and stretching, and the lens becomes a problem, and so that's what causes part of the problem. It affects efficient functioning of every gland, so it can, yes. Lisa Souza, if someone with Hashimoto's has parathyroid surgery, can that cure your Hashimoto's? Unfortunately and absolutely not. 2 different diseases just happen to be in the same location. One caused by a tumor or overfunctioning of all parathyroid glands, the other one caused by your immune system attacking your thyroid. By doing surgery around the thyroid gland, you're not going to stop the immune system from attacking your thyroid gland. Unfortunately, I wish it was the case. Jenna McLaughlin, you're welcome, Jenna. You're welcome, Lala. My doctor says urine calcium indicates no hyperparathyroidism, even with a PTH of 81 and calcium of 9.8. The only way 24-hour urine calcium would do that is if the 24-hour urine calcium is exceedingly low, like 5, right? And your doctor had done a 24-hour urine calcium and 24-hour urine creatinine and got calcium and creatinine levels at the same time to do a calculation to see if you have FHH. Because if you don't have FHH, then you have hyperparathyroidism based on the numbers you have. Sally JP, average delay in the UK 6.5 years. Yeah. For normal calcemic and normal hormonal hyperparathyroidism, patients, the delays can be many years in the U.S. as well. Kathy McCourt, this is the last question. Kathy McCourt. Had 2 adenomas removed 2 years ago. Now they have me on Forteo, which is PTH hormone. Is this going to cause problems? I do not feel so well on it. I'm getting calcium picks all over my body and taking 2 citricals per day. Before surgery, my PTH was 375 and calcium was 8.3. Wow. Now 2 years later, it is 55 and calcium 9.4. That was taken 4 months ago. Now I'm not feeling so good on Forteo. Kathy, let me turn you around and show you the study that I like to quote everybody. Let me just finish this though, since we're on it. So you can see the parathyroid adenoma. If you need to see the upper parathyroid, you can adjust the retractor and see the upper parathyroid. Remove the parathyroid, close the blood vessels, close the muscle, close the skin, put a tape on it, and you go home. So for the person who was asking about patients, you put this tape on, you shower with this tape on. The next day, you take the tape off. A week later, you can go to home, fly home the next day. For you, Kathy, I want to point you to this very important study. I mentioned it one other time during this talk of done at Columbia University, started in 1984, published in 2008. 116 patients that were given the option for surgery. Half of them chose to have surgery, half chose not to have surgery. The half who chose to have surgery, all 100% of them were cured. 100% of them had improvement in their bone density. This improvement was 10% even 15 years later. 10% improvement as compared to before surgery, even 15 years later, without Forteo. Back then there was no Forteo. Without Forteo, without these medications, without doing anything. So Kathy, I would say if you have osteoporosis, which is why your doctor is putting you on Forteo, if you have had successful parathyroid surgery, which based on your numbers looks like you did, then, I mean, I'm not sure about the calcium of 8.3 before surgery, but now calcium of 9.4, PTH of 55, I would repeat numbers and look at those along with vitamin D, but based on these, it looks like you had a successful surgery, which means you will have an improvement in your bone density without Forteo. Forteo is making you feel bad. Stop the Forteo. Okay? Do weight-bearing exercise and strengthen your bone. Make sure you have enough calcium supplements and vitamin D and vitamin K2. Let your body do the healing rather than Forteo. So happy to be here. I hope that I've been helpful today. I hope that I've made a difference in the way you approach your hyperparathyroidism and empowered you to be able to take charge of this disease. If I can be of any help, I am at your service. Have a lovely, lovely day, and I'll see you next month.